Thank you. My name is Lauren Murray. I'm a general cardiologist working for Integrated Medical Services on behalf of Summit Healthcare. It's my pleasure that I've been invited here in remembrance of American Heart Month to talk about cardiovascular disease and more specifically the importance of compliance with medication. I trained in the Northeast for internal medicine and then also trained in Los Angeles, California for cardiology training. And I've been doing cardiology medicine now for approximately 11 years. It is clear to me that of great importance is simply the compliance with medical therapy. We speak a lot about the new technologies of cardiovascular medicine, emerging research, emerging technologies, but I could tell you that from experience, that one of the more important, if not the most important thing that sometimes we even forget and fail to keep in perspective is the importance of maintaining a high degree of medication compliance. And so that's what I want to talk about today. So the primary objective of this talk, then again, is to speak about medication compliance and why this is important for all of our patients in the community at large. So Heart Awareness Month is simply that. We need to become more aware, obviously, for the benefit of us all so that we can reduce the occurrence of cardiovascular disease. So the facts first then. When I encounter patients in the office, it is a statistical fact that the majority of them are not compliant on some level. It doesn't mean that the patients do not listen to our recommendations. It does not mean that patients do not show up to appointments or complete tests. They do, in fact. It does not mean that patients don't take all of their medications. In fact, most of the patients do take, a fair amount or the majority of their medications. But the problem is that a significant proportion of patients do not take all of their medications. And as it relates to cardiovascular medicine, if you are not taking all of your medications as recommended, and this is a very standard of care approach, then you will not achieve maximal risk reduction. And so what I speak about a lot in clinic in conversations with patients is just that, reducing risk. Cardiologists, in my opinion, have a disadvantage compared to some other physicians in that we do treat simply risk. Not everything that we do results in an improvement of a symptom, whether it be chest pain or shortness of breath. Obviously, we do that stuff too. But in large part, what we are doing is minimizing risk. And so the fact is that greater than 6% of patients are not fully compliant with medical therapy, and we will get into a discussion as to why that's the case and what we can do better or how we can do better to minimize that. Now, in cardiology, the majority of what we deal with, of course, is ischemic heart disease. To this day, remains the number one cause of death. And so there's a very standard, if you will, list of medications that people should take in order to minimize risk again. That includes aspirin, statin therapy, which we all know are cholesterol medications, and beta blockers. Beta blockers are technically a blood pressure medication, but also reduce the risk of sudden death and heart attack. And so the adherence to all of those medications, which again are the standard of care in patients with ischemic heart disease, is less than 40%. And so in this month of increasing awareness, it would be very important for us to remind everyone of that. And so why this all matters. As I've alluded to, we are treating risk. If you take an antibiotic for pneumonia, it is meant to make you feel better. If you take an analgesic, whether it be Tylenol, ibuprofen, or other forms of pain medication, you physically will feel better. Cardiologists, the most common drug that we use, of course, are statins. Those are cholesterol drugs. Statins have never been known to make somebody physically feel better, but they are known to reduce risk, no different than aspirin, meant to reduce risk. Aspirin does not improve chest pain symptoms or shortness of breath, but again, reduces risk. And that is the primary focus of what we would like to achieve in a cardiovascular clinic if we are to be successful. And so the data clearly shows that if you are fully compliant with your medications, you will have a minimization of risk to the extent possible. But if you are not fully adherent to medications, then it is measurable that you will have a higher risk of heart attack and possibly cardiac death. And that's measured even within a year's time. A secondary adherence, as the slide will show, is simply not carrying out picking up a medication. Again, these are all forms of the same thing, just not complying with the extent of what was recommended. Why this matters. despite all of the emerging technologies, despite all of the emerging medical therapeutics that come out, despite the preponderance of money that's poured into cardiovascular research now over decades and decades, heart disease still remains the #1 leading cause of death. And it's not because there's not good therapies out there. It's not because the understanding of cardiovascular medicine is poor. It's not as if compliance, which we're talking about now, is the sole culprit for that either, but it does play a significant part. And I also like to remind people that when emerging technologies become available on the market, whether it be a technological advancement, whether it be a medical therapeutic, most of that applies to a very, very small percent of the population that we're dealing with. And so if there's an emerging technology that allows us to replace a valve, for instance, in the heart, that is a great technology to have. But most patients that we deal with do not have valvular disease. Whereas ischemic heart disease, i.e. blocked arteries, heart attack, that sort of thing, that is the majority of the patients that we deal with. And the emerging therapeutics for that pales in comparison, in my opinion, in terms of things that are truly impactful in the very short term. And so, comparatively speaking, then if we were to improve compliance with medical therapy, there's actually a much higher degree of success in terms of minimizing risk as compared to simply applying the latest and greatest medical therapeutics or technological advancements. Causes of non-adherence. I will be the first one to admit that the main cause for noncompliance is simply communication. There's many causes that you could get into in a very nuanced way, but they all boil down to one simple thing, and that to me is communication. And that is both sides, okay? It's if patients come to the office and we have a rapid discussion or too quick of a discussion, and patients are not fully understanding what I am trying to communicate, there will be a higher chance that they may not receive the care that I've prescribed. If I am prescribing medications that are simply too expensive without offering an alternative, patients may not realize they're too expensive until they show up to a pharmacy to pick them up and then realize that they were unable to attain this medical therapy, and then it could be some time, if ever, that we learn about that. But again, the real root cause underneath everything like that is still just communication. We must, as physicians now, healthcare providers, provide a very thorough, clearly stated, understandable reason why we are doing what we are doing. And it's our responsibility to make sure that that's understood by the patient, by their family, caretakers, whatever the case may be. And simply by focusing on that degree of communication, we can begin to consider some solutions or realize some solutions. And so the solutions then to this problem for me is very basic. It all centers around communication. If I am simply unaware that a patient is not compliant, that is a fault of my own. And so if patients are in the office now again, or if I'm contacting them by phone or vice versa, it is my responsibility to determine, are they truly compliant with medical therapy? And just through conversation, I should be able to figure that out. Other times, it's just secondary things that will clue me in that somebody's not compliant, whether it be uncontrolled hypertension or cholesterol and so forth. Then it might might indicate that maybe that patient's not being fully compliant with medical therapy. So again, all of these things we should be able to identify as healthcare providers. Now, once we understand that that issue of noncompliance may exist or non-adherence exists, then we must understand why that's the case. It is not enough for me simply to state to a patient, be more compliant with medical therapy without understanding why. I must understand or find out, are those medical therapeutics too expensive for the patient? If so, there is not a situation where there's not a reasonable and beneficial alternative for what was originally prescribed. There's always an alternative that is of lower cost. It's always the case. And if it's an issue where there was an allergy that we didn't know about, again, these are things that we must identify as providers and circumvent that and offer alternatives. And only until we realize then that there is a problem, and then we spend commit the time to understand why that is a problem, can we then be able to ultimately fix the problem? And so it's a team approach to this. It's not simply on the patient. It's also the responsibility of the healthcare provider. And that is the goal that I have personally in clinic in how I try to minimize patient non-adherence to medical therapy. With the ultimate goal, again, of minimizing cardiovascular risk, minimizing risk of heart attack, minimizing risk of death, maximizing long-term longevity and quality of life. And with that, thank you very much. Appreciate it.
My name is Dr. Adhar Seth. I'm one of the general cardiologists here at Summit Healthcare. Today I want to talk to you all about something that I've recently been seeing a little bit more of lately. And hopefully this year, this will be the last we'll be talking about this particular subject later this year. But the effects of coronavirus and COVID on your heart. The reason I want to talk about this is because as you all know, we've kind of had a little bit more patients in the hospital with COVID lately here in Arizona, and we are getting called a lot about all the different ways that the heart is affected from the coronavirus. To start off, you all know that it's mainly a respiratory virus. Most of the problems that people have are with the lungs with this particular disease, but depending on the person and the severity of the disease, it does definitely affect the heart, and surprisingly in many different ways. It's been pretty interesting for me as a cardiologist to really see all the different ways that it can affect our heart. I'll start off by, one of the more common things that people see are clotting problems with COVID. We've seen people that get blood clots in their lungs with a severe infection, and that usually requires blood thinners sometimes for the rest of their lives. One of the other ways that this disease unfortunately affects the heart is that it has caused heart attacks as well. And again, what I'm talking about some of the more severe cases. Most of the people that don't end up in the hospital commonly don't have heart issues, but the severe cases can have a heart attack from it. And the treatment is the same as any other heart attack, but it becomes a little bit more complicated because it involves a lot, special procedures that we have to do in treating patients with coronavirus. In addition to blood clots in the lungs and heart attacks, one of the other common things that we've seen is heart rhythm problems in people that have severe COVID infections. Sometimes people have atrial fibrillation, which is a pretty common irregular heartbeat. Sometimes it's atrial flutter, irregular heartbeat, a different kind of irregular heartbeat also from the upper part of the heart. And sometimes we've seen kind of just like it's called a SVT, or really another normal, really fast, rapid heartbeat from the upper part of the heart. All these things are treatable, and all these things people have even without coronavirus, but definitely a severe infection can trigger any of these other things in the heart. Lastly, one of the other things that we've seen is, particularly in severe cases, is what's called congestive heart failure or a cardiomyopathy with severe infections. And that usually is when the heart doesn't squeeze as well as normal. Again, people can get this for lots of different reasons, but coronavirus or a severe viral infection is one of them as well. It's usually treatable, usually gets better with medicines, but sometimes it doesn't. So not that you need another reason to stay safe, but definitely you want to practice social distancing, wear your mask when you can't, and get the vaccine now that it's available as soon as you can to help prevent any of these cardiovascular complications from coronavirus or COVID infection. One of the other questions I'm sure a lot of you might have is it safe to get the vaccine? And the answer is, for a majority of the people, yes, it's safe to get it. At this point in time, the only people that probably shouldn't be getting it are ones that have had a severe allergic reaction to vaccines. You know, if you have known heart disease or have had a heart bypass or have had other heart conditions, it's safe to get the vaccine. So again, if you guys have any questions or concerns, feel free to set up an appointment with any one of our cardiologists here at Summit. Like I said, stay safe, and we'll see you again next year.
Hi, my name is Riaz Sumar. I'm one of the intervention cardiologists here at Summit Healthcare, and today I'm going to talk about peripheral arterial disease. The common question that's asked very often is, why are we talking about peripheral arterial disease in the Heart Month? The reason for that is that peripheral arterial disease is an extension of the disease that affects the arteries of the heart. The disease is atherosclerosis. It is a systemic disease. It does not have any preference for what arteries of the body it affects. It can affect the arteries of the heart, it can affect the arteries going to the brain, and definitely affect the arteries going to the legs. Therefore, for a cardiologist, it's very important that we are very aware of the potential for disease in the lower extremities. Very often, we see patients who do complain of chest pain and shortness of breath, but very often those same patients also have some discomfort in their lower extremities. This discomfort doesn't necessarily have to be in the form of pain. It could be something as benign as potential fatigue. Unfortunately, when a person comes to a doctor's office and complains of lower extremity discomfort, either in the form of fatigue or heaviness or aching sensation, this is invariably treated as anything other than blocked arteries in the lower extremities. Very often I have patients who've come to me and told me that when they went to their primary care providers or to some of the other physicians, they were told that this was purely because of old age. Old age does not cause people's legs to become heavy and tired. And very often the cause of this heaviness and fatigue in the lower extremities is because of blocked arteries in the legs. Like I mentioned earlier, it is the same systemic process of plaque formation, which is also known as atherosclerosis. The risk factors for peripheral arterial disease is the same as the risk factors that causes coronary artery disease. That is high blood pressure, diabetes, smoking, high cholesterol, and very often, since all of these conditions can coexist, therefore blocked arteries that affect different anatomies, be it the heart or the legs, can coexist. Very often, patients who have history of smoking and have history of diabetes are more likely to develop peripheral artery disease as opposed to just coronary artery disease. Peripheral artery disease is basically commonly used term for blocked arteries in the lower extremities. Currently, there are various ways to make a diagnosis of peripheral artery disease. I would recommend a very simple screening tool called ABI. ABI, also known as ankle brachial index. In this test, we basically check the blood pressure in the arm and compare it to the blood pressure in the arteries going to the feet. It is a simple test that can be done in the outpatient, and that gives us an idea whether a patient has any significant blocked arteries in the lower extremities. As I previously mentioned, it is a screening tool. Why do we call it a screening tool? Because if we are able to diagnose any form of blocked arteries in the lower extremities, it is making a diagnosis of atherosclerosis. This does not mean that we need to do something about it from an intervention standpoint or from a surgical standpoint. All it means is that we have made a diagnosis of systemic atherosclerosis. Now, once we've made the diagnosis of systemic atherosclerosis, we can now treat the person a little bit more aggressively. If the diabetes is not very well controlled, we can be more aggressive in the control of diabetes. If the cholesterol is not well controlled, we can add more medication or increase the lifestyle modification to improve the cholesterol profile. Similarly, if the blood pressure is not controlled, then we can add more medications or again increase the lifestyle modification to improve the blood pressure. A diagnosis of peripheral artery disease made on the screening with ABI does not necessarily mean that the blocked artery in the legs will cause a problem for the legs. All it is doing is giving us an idea whether systemic atherosclerosis is existing in that person. Once we made a diagnosis of systemic atherosclerosis, like I mentioned, we can treat it more aggressively by treating the risk factors and definitely checking the blood work to make sure the hemoglobin A1C for diabetes and the lipid profile for cholesterol is within adequate control. Next step in the diagnosis is another simple non-invasive procedure called duplex ultrasound. In this, using an ultrasound machine, we are able to actually visualize the arteries in the lower extremities and then make a determination whether any of the arteries that are blocked have a significant blockage. If the person does have significant symptoms associated with significant blockage, then we can take it to the next level, which would be either in the form of a CT angiogram or even a peripheral angiogram. Before we go to the diagnosis of peripheral artery disease, it's important to know what can be the potential signs and symptoms of peripheral artery disease. As I mentioned earlier, the commonest sign is, as I mentioned earlier, the commonest symptoms is discomfort of the lower extremities. People invariably think that discomfort of the lower extremities can only be in the form of pain. Yes, pain can be one of the major symptoms of lower extremity peripheral artery disease, but it is not the only symptom. Very often patients present to us with symptoms of fatigue, symptoms of cramping that can wake them up from the sleep at night, as well as a discomfort in walking. They may describe that previously they were able to walk about half a block or a block, and now it's come to a point where they're not even able to walk a few yards before they get the lower extremity discomfort. All of this is suggesting that the blocked arteries in the legs is decreasing the blood flow to the muscles of the leg, and therefore the supply cannot keep up with the demand. Once we've made a diagnosis of peripheral artery disease clinically from symptoms, we can now follow through with some testing which I've described earlier. One of the main signs of peripheral artery disease is what we call as critical limb ischemia. Now, critical limb ischemia is a little bit more of a concerning sign of peripheral artery disease as compared to just fatigue or pain in the legs, which is also known as intermittent claudication. In critical limb ischemia, the discomfort has now progressed to a point where the supply cannot keep up with the demand at rest, and the person can have pain at rest, pain that can occur at rest during the daytime or even at night that will wake them up from their sleep. The next progression of critical limb ischemia is an ulcer or a sore in the feet or in the legs that does not heal adequately. That is a worse sign of critical limb ischemia, and again an indication that something may need to be done to improve the blood supply to the lower extremity. And the third and the worst case scenario for critical limb ischemia is actually gangrene, where now the blood supply is unable to keep up with the demand to even keep the tissue alive, and therefore there is what we call as necrosis or death of the tissue leading to gangrene. Any sign or symptom of critical limb ischemia, that is pain at rest, non-healing ulcer, or gangrene, usually indicates that the progression of blockage has now come to a point where it is actually causing damage to the tissue. This is a relative urgency and definitely needs to be addressed in the form of what we would call as revascularization, which means re-establishing blood flow to the muscles and to the tissues of the lower extremities. let's go back to the diagnosis. We've already mentioned that screening can be done with ABI. Another form of diagnosis is, as we earlier mentioned, is with duplex ultrasound, and then with CT angiogram, and the invasive form of diagnosis can be made by a peripheral angiogram. Now, with the advances that we made with angiography, we can actually go through a small puncture hole in the wrist and actually deliver plastic tubes or catheters all the way down to the lower extremities, where we can actually see all the arteries of the lower extremities and make a determination if any of those arteries are responsible for the symptoms and or the signs of critical limb ischemia. Once we've made a diagnosis of significant peripheral arterial disease, now it is time for treatment. As I mentioned previously, the mainstay of treatment of peripheral arterial disease is lifestyle modification. So if we have a person who smokes, smoking cessation is the most important thing that we can recommend to decrease the risk of further worsening of the peripheral arterial disease. If a person has diabetes, which is not well controlled, again, control of the diabetes is of paramount importance. Similarly, controlling the cholesterol, controlling the high blood pressure, and any other risk factors that may be associated with atherosclerosis is of paramount importance. The second most important treatment for peripheral arterial disease is increasing activity or increasing exercise. That decreases the risk of progression of the peripheral arterial disease to critical limb ischemia, and very importantly, develops collaterals. Collaterals are alternate arteries that open up within the lower extremity that can keep the tissues in the feet as well as the legs alive, even if there is blocked arteries that prevent that from happening. Oxygen supply to the tissues of the lower extremity can be provided by these collaterals, and therefore graded exercise is very often recommended for people with peripheral arterial disease. The third and the most invasive form of treatment for peripheral arterial disease is what we would call as revascularization. There are two forms of revascularization. One was previously very often used, which is vascular surgery, in which we would actually bypass the blockages. Now, with the advent of the endovascular procedures, which have seen significant advances over the past decade, we can now fix almost all of these arteries by going through a puncture wound either in the groin area or through even the radial artery in the wrist to go and fix these blocked arteries. Most of the time, when an artery is blocked, leading to what we would call as critical limb ischemia, which is rest pain, non-healing ulcer, or gangrene, it is usually associated with a 100% blocked artery. We are now capable of crossing this 100% blocked artery, be it in the thigh, be it in the groin area, or be it even below the knee all the way up into your foot. We can cross these blocked arteries with special wires, and we can open up the blockages. Previously, we did what is known as balloon angioplasty. Currently, we actually also do some form of what we call as atherectomy, which is removal of some of the plaque, either in the form of laser therapy or in the form of what we would call as calcium debulking, where we are actually removing the calcium so that when we put a balloon, and if necessary a stent, the balloon and stent results stay open for long periods of time. So currently we have significant advances in the treatment of peripheral arterial disease, and there is absolutely no reason why people who have non-healing ulcers and gangrene should not have access to those forms of treatment. We do all forms of those revascularization at our hospital in Sholo. I would recommend you speak to your physician if you have any form of discomfort of your lower extremities. Like I said, at the very least, you should get an ABI, which would be a screening tool. If you do have significant peripheral arterial disease, we can then perform further testing to assess for the significance of the blockages, and then if treatment is needed, we can take care of it right here in Summit. Thank you.
All right, so I'm Dr. Hirsch Naik, part of Summit Cardiology, and I've been asked to discuss transcatheter aortic valve replacement, or the treatment of severe aortic stenosis. So we'll just jump right into it. So first I want to kind of introduce the concept of valves. So you have four main valves in your heart: the pulmonary valve, tricuspid valve, aortic valve, and mitral valve. But we're going to just discuss the aortic valve for now. That's the main valve in your heart that allows the blood in your heart to go to the rest of your body. So it's if you want to rank the importance, it's probably one of the more important valves in our heart. So what is aortic stenosis? Aortic stenosis is a disease of the aortic valve where it becomes calcified and tight. And so now you don't have enough blood flow going through the aortic valve to the rest of your body. And you start getting symptoms, and I'm going to discuss those in a little bit. But this is what it looks like. When you're healthy, it opens. It's usually a three-leaflet valve that opens and closes based on the ejection of your heart. But as you get older, and this is generally a disease of older people, it becomes calcified and stiff, and then it doesn't open as much. And as the population gets older and we're treating heart disease a little more effectively than before, we start seeing an older population, and then now we're starting to see a lot more prevalence of aortic stenosis, as you can see from this slide. So, the elderly population will double between now and 2050. So the prevalence is going to be about 12% of the population over 75 is going to have severe aortic stenosis. And we know that if you have severe aortic stenosis and you're symptomatic, then you will, there's an 80% likelihood that you're not alive in 2 years. So that's why we take that seriously too. So what are some of the causes and risk factors of severe aortic stenosis? The main risk factor is age. So it is a disease of the elderly population. But any damage to the heart or to the valve will stimulate calcium buildup, fibrotic material, and then it becomes tight. And it gets progressively worse over time, meaning that as the valve gets older, you start seeing more aortic stenosis. But once the process starts, it's a never-ending process until you fix it. So people who have symptoms, this is what I was mentioning. People who have symptoms with severe aortic stenosis, it's really about 80%. So 80% of those patients aren't alive in 2 years. So again, we take it very seriously. So what are some of the symptoms associated with aortic stenosis? Oftentimes patients are asymptomatic, and I think it's because it's like getting old in the mirror. If you look at yourself every day, you don't see yourself getting older. But if you look at a photograph of yourself 5 years ago, you look older. And so you can tell the difference. And that's the same thing with aortic stenosis. It progressively gets worse, so you get used to it. So a lot of times you don't have symptoms. But if you do have symptoms, some of the main ones are fatigue, shortness of breath, chest pain, difficulty walking, and you can read the rest there. So how do you get diagnosed? So once you have symptoms, how do we diagnose aortic stenosis? So the main way is by an echocardiogram. Now, aortic stenosis also is very easy to hear in the chest, so I call it a medical student murmur because it's usually very loud in the chest. So auscultation and echocardiography are really the main ways of diagnosing it. So an echocardiogram, if you don't know, is just an ultrasound of your heart. So what are the treatments? With anything in the heart, we start with medical therapy. However, this is a mechanical issue that requires a mechanical fix. There's no medicine that treats aortic stenosis currently. So the old way of treating was surgical aortic valve replacement, which required open heart surgery. And that still exists, but there's a new technology called transcatheter aortic valve replacement, which we'll talk about. And that's a treatment of severe aortic stenosis not requiring open heart surgery. We also know that this is underdiagnosed, as you can see from this slide. So 40% of patients who need valve replacement do not get treatment. A lot of times it's because they're too high of a surgical risk, so they just get treated medically. But now that we have a way of treating, fixing aortic stenosis without open heart surgery, we're starting to see more and more patients getting treated. So again, don't wait to treat severe aortic stenosis because it's a mechanical issue with a that needs a mechanical fix. And so it doesn't get better without fixing it or replacing it. So when you get evaluated here, say at Summit, an echocardiogram diagnoses you with severe aortic stenosis if you have that. Then there's a whole team that's involved. That's an interventional cardiologist such as myself, a surgeon that's part of the team, an imaging specialist, an anesthesiologist, and our clinic and valve clinic coordinators. So all of us together as a team work on figuring out the best option for you for aortic valve replacement. So again, what are your options? Open heart surgery, which is this surgical aortic valve replacement here, which requires a sternotomy or cutting your chest open, or transcatheter aortic valve replacement, which has become the gold standard now in treating severe aortic stenosis. And I'll show you a video of that. Surgical aortic valve replacement, just to give you a brief overview, it requires a heart-lung machine, so you have to be on pump. It's associated with a longer hospital stay, and 3% of those patients that we know from our data and surgical aortic valve replacement data experience stroke or death at 1 year post-open heart surgery. And that's because, again, this is a disease of elderly people, so there's going to be other comorbid conditions along with treating the severe aortic stenosis. So transcatheter aortic valve replacement is less invasive. It goes through your groin, a small incision in your groin. Our procedures last about 30 minutes now, and we found that it's compared to surgery better because only 1% of patients experience stroke or death at 1 year post transcatheter aortic valve replacement. So transfemoral is the most common approach through the groin. There are other approaches, like such as the subclavian artery, or even going through your venous system and crossing over into your aorta. But generally, most of the patients have an adequate vessel size to go through the groin. So who's eligible for transcatheter aortic valve replacement? That's anyone with severe aortic stenosis now is eligible. Now, if you have a congenital or you're born with a bicuspid valve, those tend to become stenotic later on. Sometimes we do refer those patients to surgery since they're younger, and then we can do the transcatheter aortic valve replacement much later in their life. But generally, most people are eligible for transcatheter aortic valve replacement. So this is just an animation of your heart. And you can see that the aortic valve, that's where the blood goes through that valve to the rest of your body. So you see where the red arrow is going through. So the leaflets tend to have, as we get older, the leaflets get more damaged, as I mentioned, and calcium builds up. And it starts to become sluggish and not open as well. And so this is kind of the disease process. And again, this is the main valve to the rest of your body. So you can't get blood to your gut, to your brain, to any part of your body without going through the aortic valve. So this is open heart surgery, which we don't do as much anymore, like as I mentioned. And the left side of the screen is transcatheter aortic valve replacement. So generally, you come in, you lay on what's called a cath lab table. Many of you have probably had angiograms or know someone who's had an angiogram. It's a similar room setup. We put a sheath that's about 16 French, so it's about the size, a little bit bigger than the probably 2 pencil widths. And then through this, we put a balloon catheter. So oftentimes we do balloon first. We're going away from that recently. But so you put a balloon here just to open it up a little bit so you can proceed with the actual transcatheter valve, which we'll show you in a second. So they used to do balloons back in the past, but that didn't work out because that didn't last as long. So this is what the valve looks like. It's crimped onto a stent. So once it opens, then the valve immediately starts working, and you'll see this in the video. So it comes through in between your native, and it begins in your native valve, and we open it, balloon it, and the stent grabs onto the calcium, and your valve immediately starts working. And then you can see we'll show you from the inside how the leaflets work. So now you have a 3 leaflet valve. Again, it's working, and your native valve gets pushed to the side. And so there are risks involved in any procedure. You can read it there. But again, when we compared it to surgical aortic valve replacement, there was less bleeding, less death, and less stroke in the transcatheter aortic valve arm. That's transcatheter aortic valve replacement. So again, just in conclusion, it's a common disease in the elderly. About 12% of patients above 75 are going to have severe aortic stenosis. The mortality, if you don't do anything, is up to 80% after 2 years. So we do take it seriously. So please see your cardiologist if you have any symptoms of shortness of breath or chest pain or anything that we talked about, so we can get you diagnosed early and treated. Thank you.